Welcome to the Gastrointestinal Endoscopy Author Interview Series. My name is Glenn Eisen. I'm the Editor-in-Chief of GIE. Today I'll be talking with Dr. Richard Zubarik, who is an Associate Professor of Medicine at the University of Vermont, and we'll be chatting about his paper that's soon to be published in GIE, Screening for Pancreatic Cancer in a High-Risk Population with CA19-9 and Targeted EUS. Dr. Zubarik, welcome.
Thank you.
How are you?
Doing well, thanks.
So can you tell me the premise behind your paper? What prompted you to look into this area?
So pancreatic cancer is the fourth leading cause of cancer death in the United States. And unfortunately, it's often detected too late at a point when we cannot do curative therapy. Right now, we detect this disease when symptoms arise, such as jaundice or weight loss. It would be better to detect this disease earlier when treatment can still potentially be curative. It's known that if you detect the cancer when it's confined to the pancreas, that survival rates are higher with surgery. Screening efforts have been tried in the general population. However, the incidence of pancreatic cancer is probably too low to screen the general population, so higher risk populations have been targeted. Patients have targeted very high-risk patients with multiple affected family members with pancreatic cancer, with endoscopic screening, with EUS, with CT and MRI in various studies that have shown some efficacy. I was interested in looking at the patient population that's somewhat broader, that patient population that just has one affected family member, first-degree relative with pancreatic cancer, and seeing if we can come up with a screening strategy that could effectively screen these people and detect the disease earlier. What I attempted to do in that patient population, the incidence is probably too low to start off with some form of imaging, such as endoscopic ultrasound or CT, and I sought for some tumor marker that could be used initially to screen through people to then, when that screen marker was elevated, to then do endoscopic imaging with endoscopic ultrasound. And the marker that I used was the CA19-9 for that purpose.
Okay. What fraction of the population constitutes this high-risk group that you think might be amenable to screening?
So 10% of people with pancreatic cancer have a first-degree relative with pancreatic cancer. So we're talking about 10% of that population who will ultimately develop pancreatic cancer.
Okay, and you utilize the carbohydrate antigen CA19-9 as the first screening intervention?
Correct.
How did you decide what level would be considered high enough in order to prompt secondary screening with an endoscopic device?
So back in the literature of the 1980s, they looked at what level would be best to discriminate pancreatic cancer patients from non-pancreatic cancer patients, and they found that the sensitivity and specificity was maximized when a cutoff of 37 was used, and so we used that from the older literature as the cutoff.
How often do you think you'd have a false positive result if you're doing mass screening?
So in this patient population with one affected first-degree relative, and also this includes only patients between the ages of 50 and 80. So we also used age as a limiting factor as well. In this patient population, from our study, 5% of people had an elevated CA19-9. So of the 546 people that we screened, 27 people had an elevated CA19-9 and subsequently underwent endoscopic ultrasound.
And what were your findings with those tests?
So we found that there were 5 patients with pancreatic neoplastic disorders. One patient had pancreatic adenocarcinoma stage 1. We had one neuroendocrine tumor. We had one mucinous neoplasm. An IPMN was detected, and a PANN1 cystic lesion.
Okay,
was seen.
So for the patients who didn't have a positive FNA or follow-up surgical removal, the ones that had an elevated CA19-9, how did you show that they were not going to develop pancreatic cancer?
So we did it in a couple of ways. One, we know that if an endoscopic ultrasound is normal, the chance of someone subsequently developing pancreatic cancer is almost zero. So if the EUS was negative, we didn't do any further screening, but we did follow up those patients a year after the study began. If there was any abnormality seen on the EUS, we did a CA19-9 follow-up 3 months subsequently, and if that was elevated, we repeated the EUS.
So you found 1 out of 546 patients that had a pancreatic neoplasm,
Right.
presumably at an earlier stage?
Right. So we compared the patient that we detected pancreatic cancer as part of our study to all the patients that presented to our institution with pancreatic cancer during that same time, which was 124 patients. Mm-hmm. Of that 124 patients that presented off protocol to our study, only 1 patient had stage 1 disease. And we compared this to the 1 person detected with stage 1 disease in our protocol who also had stage 1 disease, and found that you were significantly more likely to have stage 1 disease detected on our protocol than if pancreatic cancer was detected through standard detection processes.
Okay. So admittedly, this was a small cohort, and you did have a finding with some stage shifting. Mm-hmm. Not a randomized trial, but it's suggestive that this may have some efficacy. Mm-hmm. Since this study's been completed, how are you following patients at risk if you adopted this into your practice?
So this is a feasibility study. I don't think that this study per se should then be adopted, generalized to screening for pancreatic cancer. However, I think it's a start, and I think larger studies with more patients should be performed to really figure out the cost and the efficacy of this approach. And as far as how often to screen in the future, I think that's an interesting question, and I think it's out there for future studies as well. We don't know if you should repeat a CA19-9, for example, in 3 years, 5 years, or never again. I think that's up for future debate and study.
Okay, so if you needed to summarize this for our readers, sort of as far as a take-home message and how their practice perhaps should change, even though this is a feasibility study, what would you recommend?
Well, I think the 2 major findings from this study was that early detection of pancreatic cancer can happen with the screening protocol. The 1 patient that we detected is alive now 4 years subsequent to cancer detection with a CA19-9 level that's now normal, so we can detect early stage disease and prevent and potentially cure these people of pancreatic cancer at a higher rate. I also think that there is stage shifting and that stage 1 disease is more likely to be detected through our protocol than through standard means of detection. I don't think it should be standard of care yet. I think that future study needs to be performed in order to figure out the details and cost of this. And I don't think it should change practice at this point.
Okay, thank you very much, Dr. Zubarik.